Now, what if there was a diabetes drug that didn't just control your blood sugar, but also help you lose nearly 17% of your body weight in less than a year without a plateau in sight? That drug just had its first major phase 3 trial results published in the Lancet, one of the most prestigious medical journals in the world, and presented a few weeks ago at the American Diabetes Association's 86th Scientific Sessions in New Orleans. It's called Retatrutide. It's made by Eli Lilly, the same company behind Mounjaro and Zepbound. And what makes it different from everything else out there right now is that it's the world's first triple hormone receptor agonist, hitting 3 targets instead of 2. A few weeks ago, I broke down the top line numbers from Triumph 1. That's the phase 3 obesity trial for Retatrutide. So if you haven't seen that yet, go check it out. After this, link is in the description. Today, we are going deeper on the other side of the story, what this drug does specifically for people with type 2 diabetes. We're breaking down the Transcend Type 2 Diabetes 1 trial, how those results stack up against Tirzepatide, which you probably know as Mounjaro, and what this could mean for the future of type 2 diabetes treatments. Let's get into it. So you've probably heard of GLP-1 drugs, semaglutide, that's Ozempic and Wegovy. It's a GLP-1 receptor agonist. It mimics a gut hormone that tells your pancreas to release insulin, slows your digestion, and reduces appetite. Then Tirzepatide came along, Mounjaro for diabetes and Zepbound for weight loss. It hits 2 receptors, GLP-1 and GIP. That second receptor, GIP, turbocharges the insulin response and adds another layer of appetite suppression. That's why Tirzepatide has been such a step up from the original GLP-1 drugs. Now, Retatrutide as a third receptor, the glucagon receptor. And here's where it gets really interesting. Glucagon is usually thought of as a raised blood sugar hormone. It's the thing diabetics take in emergency kits when blood sugar crashes too low. So you might be wondering, why would you want to activate glucagon receptors in a diabetes drug? The key is how it's activated in combination. When glucagon receptor agonism is paired with GLP-1 and GIP signaling, the blood sugar raising effects gets offset. The insulin stimulating hormones keep glucose in check. But what you don't lose is glucagon's other superpower. It directly fires up thermogenesis in brown fat tissue and drives fat burning in the liver. In other words, it increases the number of calories your body burns at rest through a mechanism that GLP-1 drugs alone simply cannot replicate. So with Retatrutide, you're getting a two-sided attack on weight, less appetite, and a higher metabolic burn rate. That's the theory. And the Transcend Type 2 Diabetes 1 trial is the first phase 3 test of whether that theory holds up in the real world for people with type 2 diabetes. Okay, let's talk about the study itself because context matters a lot when you're interpreting clinical trial results. Transcend Type 2 Diabetes 1 was a 40-week, double-blind, randomized, placebo-controlled phase 3 trial. Double-blind means neither the patient nor the doctors knew who was getting the drug versus placebo. That's the gold standard. The trial enrolled 537 adults with type 2 diabetes who had inadequate blood sugar control on diet and exercise alone, meaning no other diabetes medications. So these were people in the early stages of managing their type 2 diabetes, relying on lifestyle changes that weren't quite cutting it. To be in the study, participants had to have an A1C, that's the 3-month average blood sugar marker, between 7% and 9.5%, and a BMI of at least 23. The average baseline A1C going in was about 7.9%, and the average disease duration was only 2.5 years. Participants were split into 4 groups, each getting a once-weekly injection: Retatrutide 4 milligrams, Retatrutide 9 milligrams, Retatrutide 12 milligrams, and then placebo. And then everyone was followed for 40 weeks to see what happened. The results were simultaneously published in the Lancet and presented on June 6 at the ADA's 86th Scientific Sessions in New Orleans. And one quick note before we get into the results. I'll be comparing these results to Lilly's Surpass-1 trial for Tirzepatide, which had an almost identical design, also 40 weeks, also monotherapy versus placebo, also in people with diet and exercise only, inadequate control, also with a mean baseline A1C of 7.9%. It's the fairest comparison we can make without a head-to-head trial, which doesn't exist yet. So keep that in mind. All right, the results. Let's start with the blood sugar because that's the primary reason you take a diabetes medication. At 40 weeks, Here's what happened to A1C. Retatrutide 4 milligram, A1C dropped by 1.69%. The 9 milligram dropped by 1.86%. The 12 milligram dropped by 1.94%. And placebo dropped only by 0.81%. So at the highest dose, you're getting nearly a 2-point drop in A1C compared to about 0.8 with just placebo. That is a clinically massive difference. Now let's talk about what percentage of people actually hit the targets that matter. 90% of participants on retatrutide reach an A1C below 7%. That's the standard recommended target for most people with diabetes. 85% reach 6.5% or below, which is considered excellent control. The placebo group, on the other hand, had a much lower drop, which is something that you would expect. Now, how does that compare to tirzepatide? In Surpass 1, the comparable tirzepatide monotherapy trial, tirzepatide reduced A1C by 1.87% at 5 milligrams, 1.89% at 10 milligrams, and 2.07% at 15 milligrams versus placebo. And 87% to 92% of tirzepatide patients reached A1C below 7%. Here's the honest takeaway. The blood sugar results are remarkably similar. Retatrutide at its top dose hits about 1.94% A1C reduction. Tirzepatide hits 2.07%. We're talking about a difference of just over a tenth of a percentage point. Both drugs get about 90% of patients to goal. If blood sugar control was the only thing that mattered, you'll look at these two drugs and say they're basically equivalent. But blood sugar isn't the only thing that matters anymore. And this is actually a really important shift happening right now in diabetes care. The ADA's 2026 standard of care, unveiled at this same meeting, now formally requires cardiovascular and kidney risk reduction to be co-primary treatment goals alongside blood sugar control. So with that in mind, let's talk about weight, because that's where the story changes. This is the part that made headlines, and honestly, it really should. In Transcend Type 2 Diabetes 1, participants taking retatrutide 12 milligram lost an average of 36.6 pounds. That's 16.8% of their body weight at 40 weeks. And critically, there was no plateau observed. The weight loss curve was still going down at the end of the trial. We don't know where it levels off yet. Now compare that to Surpass 1, the equivalent Tirzepatide trial. Tirzepatide 15 milligram produced an average weight loss of 20.9 pounds, roughly 11% at 40 weeks. That's about 75% more weight loss with retatrutide versus tirzepatide in a comparable trial design at a similar duration and a similar population. Now, important caveat here, and I want to be transparent about this. This is not head-to-head data. We are comparing across two separate trials. Populations are similar, but not identical. Transcend Type 2 Diabetes 1 patients had a shorter average disease duration of 2.5 years compared to 4.7 years in Surpass 1. People earlier in their disease course often have better beta cell function still intact, which could slightly boost weight and glucose responses. But even accounting for that, a difference of 15 pounds in average weight loss is hard to explain away by population differences alone. The third receptor appears to be earning its keep. Think about it this way. Tirzepatide pulls two levers. It reduces how much you want to eat, and it makes insulin work better. Retatrutide pulls those two same levers, plus it essentially turns up your body's internal thermostat, burning more calories, even at rest, through that glucagon-driven thermogenesis effect. The extra lever appears to translate to meaningfully more weight loss in people with type 2 diabetes. And for people with type 2 diabetes, where weight is such a central driver of the disease itself, that matters enormously. And it wasn't just weight. Retatrutide also produced triglyceride reductions of up to 39.6%, non-HDL cholesterol reductions of approximately 19.8%, and systolic blood pressure down 6.4 mmHgs. Waist circumferences were down 4.9 inches. These are the kinds of numbers that move the needle on long-term cardiovascular risks, which, as we just mentioned, is now officially a co-primary goal in diabetes treatment. Now let's talk about the side effects, because I know that's top of mind for a lot of people out there. The short version, retatrutide's safety profile looks very consistent with what we already know from the GLP-1 class. No major surprises. The most common side effects were gastrointestinal, which is nausea, diarrhea, and vomiting. That's the same pattern we see with semaglutide and tirzepatide. These GI effects are typically most prominent during the dose escalation phase and tend to improve over time as the body adjusts to the medication. The discontinuation rate due to adverse events, meaning people who had to stop the drug because of side effects, range from 2.2% to 5.1% across the three retatrutide doses, compared to 0% in the placebo group. For context, tirzepatide's discontinuation rate in Surpass 1 was under 7% in each treatment arm. So, if anything, retatrutide looks at least as tolerable as tirzepatide, possibly slightly better. Though, again, these aren't head-to-head numbers. One concern that came up theoretically before this trial was that adding glucagon receptor agonism might worsen blood sugar control or cause hypoglycemia, since glucagon raises glucose in other contexts. The data so far suggests that concern doesn't materialize in practice when the glucagon receptor is co-activated with GLP-1 and GIP. The insulin stimulating hormones appear to keep glucose in check, and that's a reassuring finding. I did a full breakdown of retatrutide's obesity results in a previous video. Link is in the description of this video, but just to connect the dots, at the same ADA meeting, Lilly also presented results from Triumph 1, the companion phase 3 trial in people without diabetes who had obesity. In that trial, participants lost an average of roughly 26 to 28% of their body weight at 80 weeks, with some subgroups approaching 30%. These are numbers that rival bariatric surgery territory. The type 2 diabetes results we've been talking about today, 16.8% weight loss at just 40 weeks, still no plateau, are consistent with that obesity trial data and suggest the drug may have even more to offer the longer it's used. So, where does all of this leave us? Retatrutide isn't approved yet. It's still investigational, meaning it's not something your doctor can prescribe right now. Eli Lilly has said they plan to pursue FDA approval based on this trial data and their broader Transcend program. Speaking of which, there are additional trials underway that will be really important to watch. Transcend Type 2 Diabetes 4 is comparing retatrutide directly against semaglutide in type 2 diabetes. That head-to-head data will be significant. And Transcend Type 2 Diabetes 2 is evaluating retatrutide in patients on metformin with or without SGLT2 inhibitor. And Transcend Type 2 Diabetes 3 is looking at retatrutide combined with insulin in people who also have chronic kidney disease. And Triumph 3 is evaluating it in people with obesity and cardiovascular disease, the long-term outcomes data that regulators and cardiologists will want to see. Here's how I'd frame the big picture for you. We are living through a genuinely remarkable moment in diabetes and metabolic medicine. For decades, treating type 2 diabetes was mostly about managing A1C and hoping you could slow the progression. Then GLP-1 drugs changed the game. Then tirzepatide pushed it further, and now retatrutide is potentially pushing it even further still. Not just on blood sugar, but on weight, on triglycerides, on blood pressure, on all the downstream things that actually determine whether someone with type 2 diabetes develops heart disease or kidney disease over their lifetime. And with the ADA's decision to formally update their standards of care this year, making cardiovascular and kidney protection co-equal goals with blood sugar control, is not a coincidence. It reflects exactly where the data is pointing. The era of treating diabetes by looking at one number on a lab report is coming to an end. Drugs like retatrutide are part of what's replacing it. All right, that's the full breakdown of Transcend Type 2 Diabetes 1, how retatrutide compares to tirzepatide on type 2 diabetes. A quick recap of the key takeaways. Retatrutide is a triple agonist, GIP, GLP-1, and glucagon, the first of its kind to reach Phase 3. In type 2 diabetes, it reduces A1C by up to approximately 2%, comparable to tirzepatide. 90% of patients hit the A1C below 7% target. Weight loss of 36.6 pounds or 16.8% at 40 weeks, roughly 75% more than tirzepatide in comparable trials, with no plateau. Strong cardiometabolic benefits on triglycerides, cholesterol, and blood pressure. Safety profile consistent with the existing GLP-1 drug class. Not yet FDA approved. More trials and regulatory reviews are ahead. If you found this helpful, hit that like button. And if you're watching on the mobile app, hit that hype button. It generally helps this kind of medical content reach people who need it. Subscribe if you want to stay ahead of what's happening in diabetes and metabolic health research. And drop a comment below. Are you currently on a GLP-1 drug for type 2 diabetes? And what has been your experience? I'll see you on the next one.